thank the co-sponsors of this webinar, who are Oncologists United for Climate and Health and GreenHealth Lab. And then I'll go ahead and introduce our moderator for tonight's session, who will be introducing our speakers. Dr. Caitlin Rublee is an assistant professor in the Department of Emergency Medicine at the University of Colorado School of Medicine and Colorado School of Public Health. She serves as vice chair of the Medical Society Consortium on Climate and Health, who we are the New Hampshire state affiliate of. And she is the 2022 to 2024 American Board of Emergency Medicine National Academy of Medicine Fellow. Dr. Rublee completed a Climate and Health Science Policy Fellowship and continues to advance population health through research and evidence-informed policies focused on international climate justice and health. So, Dr. Rublee, thank you so much for moderating tonight's session, and I will pass the floor over to you.
Well, thank you so much, Emily, and for all of you for being here tonight, and for all of those who are watching after the fact. I hope you are as excited as I am that we really get to have two experts when it comes to cancer and climate change. I know I'm excited to learn from them. I have learned a lot from their work, and I'll go ahead and give you a very brief introduction. But I encourage you all to read their papers because they're phenomenal, and really think about the intersection of climate change, climate justice, and health, and what a transformed system can be as we move forward and think about healthcare delivery in the setting of climate change. So our first speaker will be Dr. Joan Schiller, who is a widely published medical oncologist, internationally recognized for her work in lung cancer clinical research. She is also passionate about climate change and its impact on health, hence why she is sharing her expertise with us here tonight. She is the co-founder and chair of the steering committee of Oncologists United for Climate and Health, or OUCH, a nonprofit organization that you will hear more about shortly. Dr. Schiller has published numerous articles, editorials, and opinion pieces on the effects of climate change, and has given multiple talks and webinars. She's the Deputy Director of Clinical Investigation for the Nova Shar Cancer Institute in Fairfax, Virginia, and Chief of Hematology and Oncology. But we did not leave you with just the East Coast, and we wanted to translate the West Coast as well, because we know that place is a powerful driver of health, and unfortunately, all parts of the U.S. are impacted. So second, we'll have Dr. Katie Lichter, who is a resident physician in the Department of Radiation Oncology at the University of California, San Francisco. She is also a principal investigator at GreenHealth Lab. I will put their website in the chat for you to explore even further. Just really phenomenal work leading on decarbonization and the role of healthcare delivery in the setting of the climate crisis and ongoing emissions as well. She has published multiple papers. I encourage you to read them as well, and is really a rising star when it comes to addressing healthcare delivery on a changing planet for our patients and for each other. So without further ado, Dr. Schiller, please, I welcome you. Thank you so much for being here. And for the rest of the participants, I encourage you to post questions in the chat, thoughts, reflections, and we'll be sure to get to those as the night goes on.
Great. Thank you. Thank you very much, Caitlin, for that very kind introduction. Can you folks see my screen? Okay, good. So as Caitlin mentioned, I'm a medical oncologist. Most of my career was spent doing research on lung cancer and how to improve therapies. But eventually, obviously, I got into climate change. And how did that happen? So we have my husband and I have a cabin in Southwest Colorado, and for over 10 years, and we've been going there. And as you can see, it's really beautiful. It's nice and green, and we've really enjoyed it until this happened. And this is, you can see that many of the trees are dying, and that's because of this guy, the spruce beetle. The trees in the area are much more vulnerable to the spruce beetle due to the fact that they've had droughts And so you can just see how many of the trees are dying. And then something else happened that really kind of brought it home for me. And that is in 2017, I had a new granddaughter, in addition to my grandson, who at that point was 3.5. And this is Dylan, who's very cute. But also what happened right around that time was forest fires. And I know you folks know about forest fires and how they have been increasing in intensity and duration. And that happened in Colorado as well. And so in 2020, it was an unprecedented wildfire season, the 3 largest fires in Colorado history. And they were about, I would say 100 miles from our cabin, which at the time was pretty scary. But it didn't just affect our cabin or southwestern Colorado. So my grandkids are in Madison, Wisconsin. And this is a scene of a sunset in Madison and right around that time. And you can really see that the hazy sunset is due to the wildfires from the west, which was hundreds and hundreds and hundreds of miles away. So here we are now, 6 years later. This is Dylan now, who's 6, and Bennett, who is 9, and they're cute, still cute as can be. But of all things, air pollution, climate change has gotten worse, not better since that time. And in 2021, the World Health Organization called climate change the single biggest health threat facing humanity. And yet climate change is often perceived by the public as an environmental threat or a political problem or a social problem. And what is largely overlooked is that climate change and air pollution markedly impact healthcare delivery and outcomes, including cancer care. So I'm an oncology health professional. I'm not a climate scientist, and this was very upsetting to me. So I obviously was thinking, what can we do about this? So several of my colleagues and I decided to make the health, and particularly the oncology professional, to them that the warming of the planet is a health issue and a cancer issue, because it seemed that that was largely unrecognized at the time. And since then, to recognize how we have grown, and more importantly, the international expertise of our members, we have recently changed our name to Ouch International. And that's to recognize, as I said, and welcome the many people that are out there, the many healthcare professionals. Let me just make sure I got, yeah. And our mission is to advance awareness, actions, and policies that mitigate the effects of climate change on cancer care. And our goals are to educate stakeholders, patients, oncology healthcare professionals, et cetera, on the link between climate change and cancer, to advocate for sustainable cancer care, and to advocate and promote actionable steps in climate mitigation, advocacy, and research. We have now about 150 members, about 2/3 of whom are in the United States and 1/3 outside the United States. They come from 31 different states. We're hoping to get to all 50, as well as 22 different countries. What, let me just see here. One of the, so as Ouch, like I said, we started out saying oncologists are united for climate and health, but to recognize that many, many oncologists are involved in this, we changed our name also to Oncology Advocates United for Climate and Health. And that's to welcome any individual or organization who works as a cancer care provider or who studies the effects of climate change on cancer or who advocates on behalf of cancer patients. I'm just looking for, which I can't find. I had a slide here, I thought, but I can't find it, about some of the things we do. As an organization, these include lectures and educational talks such as this one, again, to healthcare professionals as we've defined it. Writing, we have written papers, letters to the editor, advocating for advocacy. We have testified in front of the EPA, and we want to serve as an umbrella organization for the many healthcare organizations and cancer professional organizations that are out there. So with that, I think I will, oh, here this was. I'm sorry, it was out of place. Again, some of the things that we have done, including most recently an open letter from OUCH to policymakers. So this is an open letter stating that there's abundant evidence that climate change and pollution of our environment from fossil fuels significantly impact our ability to treat and care for cancer patients. We plan on using this open letter when talking to policymakers, politicians, other healthcare providers to help make our point. And please feel free to add your signature by going to OUCH's Climate and Cancer Sign-On. And with that, I'd like to thank you for your attention, and I'd like to welcome Katie Lichter, who's done a phenomenal job with our group. Thank you.
Great. Thanks, Joan. Really, really inspiring. And I was excited to have met Joan early on in my career here, which I'll talk a bit about more. Let me just share screen. All right. Slides are good?
Yep.
Yes.
All right. Fantastic. Well, thanks again, Joan. And good evening, everyone. I'm really thankful for the invitation to be able to join tonight and am honored to be able to talk on this topic that I'm so passionate about. So I'm going to be speaking from an oncologic lens and my experience navigating as a resident in radiation oncology, but I hope that there's going to be takeaways pertinent for all of healthcare providers, regardless of specialty, to talk about decarbonization. And before we talk about our specific projects, I'll just jump in and give a little bit of background on climate change and its connection to cancer care. Also, typically start off with my own journey as well. I love to see how all of us, have navigated to this space. But originally I'm from Minnesota. And so the appreciation and advocacy for the protection of our land and our communities that inhabit these spaces really was woven into my upbringing, spending summers canoeing the over 10,000 lakes that we're known for. But it was actually in my intern year that I saw the link to health and how this was going to incorporate into my career. So it was an overnight shift that I was working in the COVID ICU units when a gentleman was admitted with progressively worsening lung cancer. And due to the wildfires in Northern California, he had been displaced from his home and he had missed several weeks of essential chemoradiation. And so as I walked home, the skies were dark. It was actually the day of the orange skies. And I began to realize that the story of this single gentleman was not unique to my patients, or not unique to this single patient, but that my patients throughout my career were going to be affected by climate change, whether it be wildfires or a global pandemic. But simultaneously, as I stripped off all the PPE and I grabbed my reusable grocery store bag, I felt a call to go beyond just using reusable grocery store bags and composting at home and begin to question how the medical field is actually contributing to climate change. And so ultimately, I sought to answer three questions. One, how does climate change impact cancer care or patients? How does cancer care on the flip side impact climate change? And then how can we organize to inspire change? Essentially, how can I do this within oncology, exactly what your group has been able to do? And so I'll run through some of this background information, but today we know that climate change is a growing threat to public health. And that is due to a variety of reasons. And we know that climate change impacts health and outcomes as rising temperatures and changing weather patterns associated with climate change fuel extreme weather events. And such events, have wide-reaching impacts on patients. But tonight, I mainly want to focus on how climate change impacts cancer care. Unfortunately, oncology is not immune to climate change, with known impacts all across the cancer control continuum. And this includes increased risks of cancer from increased exposures, whether that be air pollution or chemical toxicants, even infectious etiologies of cancer. As Joan went into, we know that air pollution is a major cause of lung cancer deaths today. But when you're looking down the cancer control continuum, we also know that climate change related disasters disrupt essential health systems and behaviors needed for detection, diagnosis, treatment, and even follow-up or survivorship care. And we saw this not only in times of COVID with patients missing preventative screenings, but also extreme weather events when patients' treatments and follow-up appointments can be disrupted. For example, we know that U.S. hospitals have experienced an average of 4.2 extreme weather events over the last 5 years. And between 2000 and 2017, there were 114 climate-related hospital evacuations. So really affecting us nationally. And so going one level deeper, and what I would argue is key to building awareness and information for both future climate action is to understand how the impacts are on our specific patients. So we looked at California, and our team did a survey of all 176 California radiation oncology clinics. And we found that out of 176, all 176 were within 25 miles of a wildfire just within the last 5 years. So that's certainly a radius that captures many of our patients' homes and communities. And when we surveyed these clinics, 60% reported direct impacts on their clinics and staff, with common impacts being clinic closures, home evacuations, financial burdens, and staffing shortages, and even power outages, just to name a few of them. And so we know that such impact, or these events impact not only these clinics, but it also impacts cancer survivorship. So our team at UCSF looked at wildfires using national FEMA data, and then we used NCDB, a national cancer registry, and we looked at the wildfires' impact on lung cancer patients receiving radiation. And we found that not only do patients have longer treatment times, meaning that they're missing some of their appointments, but they also had worse 5-year overall survival. And then going one step beyond that, we also know that climate change further magnifies healthcare disparities as the effects have disproportionate impacts on the most vulnerable patient populations. And cancer is just one component of this. So I'll speed through some of this because I know this group is well educated on this, but I'd like to add the oncologic lens. So when we think about patients who are at increased risk or are particularly vulnerable to climate change, I found this framework to be really useful. There are 3 factors that determine vulnerability to climate hazards. And one is exposure, human contact with environmental hazards. The second is sensitivity, the degree to which climate hazards impact humans. And then the third is adaptive capacity, the ability to cope with climate hazards. And so when we're looking at a subset of patients, such as cancer patients, we can begin to understand how they are particularly vulnerable to health hazards of climate change. With cancer patients, they have unique physical, psychological, and socioeconomic consequences of both their diagnosis and the treatment. And so I'll walk us through understanding how these patients have increased sensitivity to the health hazards of climate change. For example, some cancer treatment drugs can inhibit thermoregulation, leading to vulnerability during times such as heat waves. Additionally, patients can have impaired organ function that may similarly alter their ability to respond to heat waves or poor air quality. And also often weakened immune systems that makes individuals more vulnerable to infections, which can be quite common during climate-fueled disasters such as flooding. And then certainly there are cognitive and psychological impacts that also increase sensitivities. But also cancer diagnoses and their treatments have socioeconomic consequences that may reduce a patient's adaptive capacity. For example, there are numerous expenses that arise during treatment and survivorship that can affect patients' ability to remain employed and may ultimately reduce their adaptive capacity. And patients may have reduced ability to evacuate or to seek daily transportation required for their therapies, or to adapt their housing infrastructure to cope with extreme weather events or poor air quality, such as improving insulation or installing AC units or specialty air filters during wildfires. And then this picture shows a spike of EMS calls and notes that there was an increase in ED visits during a heat wave in 2007. And I always like to bring this up for oncologists to highlight that it's certainly reasonable to think that this spike in both calls and visits would include our vulnerable cancer patients who are undergoing active treatments and lack the adaptive capacity to respond to such events. And we certainly know that people are more than their cancer diagnoses. And due to how our society is structured, different individual characteristics, including the groups that we are racialized into, our gender identity, the language we speak, and our socioeconomic status all can impact vulnerability to health hazards of climate change. One of the most widely recognized examples of this is redlining. And I think this is a picture that I like to show here in San Francisco. On the left, we can see the redlined communities of San Francisco. And interestingly, and unfortunately, when we fast forward to today, on the right, we can see how these same neighborhoods are disproportionately exposed to environmental hazards, including nitrogen dioxide and PM 2.5, or poor air quality. All things that can impact cancer care diagnoses. And it's not just air quality, it's also heat. We additionally know that these same neighborhoods are disproportionately exposed to higher temperatures. And we can see that here on the right, which shows that there's consistently higher temperatures in formerly redlined areas relative to the non-redlined neighborhoods by as much as 45 degrees. And these trends can be attributed to impervious surfaces, meaning, more asphalt and concrete, which can create urban heat islands simply due to less investment in green spaces, parks, and even fewer trees planted. And then this is a local San Francisco KQED report that shows temperatures in an individual's SRO apartment reach temperatures as high as 80 degrees, even though outdoor temperatures were only in the 70s. And so again, I like to highlight this because if we're thinking about patients undergoing active chemoradiation who may be living in an SRO, we can certainly begin to understand how they are more vulnerable to climate change hazards. So then this led to the question, are our cancer centers ready to respond to a changing climate? And this is a study that we published in JAMA. And unfortunately, we found when we investigated all the NCI centers across the United States, that in fact, they are not prepared to deliver care in a changing environment, with only 2 of the existing cancer centers having environmental sustainability plans in place. Although I will highlight here that the silver lining is that significant opportunity does exist, given a large percentage of their affiliated hospitals and universities did have formal plans in place and opportunities thus to collaborate. And this was similar across California and radiation oncology facilities, with results from our survey that I mentioned before showing that only half, 25 out of 51, had known wildfire emergency plans in place, with only about a quarter of the physicians reporting that patients are counseled on emergency preparedness planning and what to do in the event of a wildfire. Again, highlighting an opportunity for establishing adaptation and resiliency within each of our clinics. And so then this led to my second question, which is, what is healthcare's impact on climate change? Again, a topic that I think that this group is familiar with. But just briefly, we know that healthcare contributes approximately to 8.5 to 10% of US greenhouse gas emissions, with a variety of the sources coming from scope 1, 2, and 3. Certainly hospitals produce a significant amount of physical waste, with about 29 pounds of waste per hospital bed per day, presenting an opportunity for environmental stewardship. But also we like to highlight within our cancer centers an opportunity to decrease spending, as many climate actions do. And so the natural next question that I had when I entered this space is, how do we go about calculating greenhouse gas emissions or environmental impact? And just briefly, this can be done using a tool called life cycle assessments. Life cycle assessments are a tool that quantifies the environmental emissions or impacts of a product or a process throughout its entire life cycle, all the way from raw materials through disposal. And so, for example, if we're thinking about radiation therapy, it may appear just to be a moment in time. But in fact, there are many things that go into the patient pathway, including supplies, energy, capital equipment, transportation, and the hospital infrastructure. And so in reality, it's a complex process that needs all of these components in order to have a successful patient treatment. And each component in the pathway, whether it's a supply item or capital equipment, they all have an upstream workflow, which we can say here, where they go from raw materials to production and extraction, until they're ultimately transported to the clinical site where they're used. But then each item also has a downstream component or end of life cycle process, whether it be recycling, reuse, or landfill. And each one of these steps ultimately has a footprint, or their emissions associated with each one of these. And so importantly, LCAs provide a holistic understanding of these impacts, not only greenhouse gases, but it's also important to think about the other ecologic impacts, such as the land use, ozone depletion, acidification, and even water depletion. And then ultimately, these environmental impacts can also be translated into endpoint impacts, meaning how do these environmental changes in turn impact human health? This is most commonly reported in DALYs, and I've found this to be a very useful term when we're talking to healthcare professionals. And so within healthcare, LCAs have been used for a variety of reasons, including quantifying baseline emissions and identifying hotspots. They've also been used to quantify waste, such as in emergency departments. And then they can also look at, they can also compare single-use or reusable products, such as reusable laryngoscopes, gowns, or even speculums. And so ultimately, this is the tool that we decided to use to start to understand what the environmental impact was of cancer care. So I'm going to walk through an example of an LCA that we performed for radiation oncology to answer this question of both environmental and human health impact. And so we looked at a complete treatment course, all the way from initial consultation through their last treatment delivery. And we looked at everything that went into this, including all of the raw materials, the production, the transportation, energy, and supplies. And then in the end, we put all of these into our cycle. And in the end, you can get the environmental impact per treatment course or even per day of treatment, and then translate that into human health impact. And so for our LCA, we collected data from 4 institutions in order to make our results more broadly applicable. And then we looked at 10 cancer types, including breast, CNS, GI. They're all right here, including skin and musculoskeletal and thoracic, again, just to get a really broad understanding. And our goal really was to understand what are our baseline emissions, where are their hotspots, and then with that, where are there opportunities for mitigation? So I'm going to move quickly through this, but essentially we spent 3 months collecting data in our clinics, including documenting all the supplies we used, including material type, the weight, the lifetimes, and this was done with direct observation and weighing, but also through secondary data collection via discussion with procurement officers and also through review of product data sheets. And then we spent time with buildings and facility management teams, understanding our building energy use and the energy use of all of our capital equipment. And we even looked at UCSF zero carbon energy, which utilizes renewables, understanding that hospitals and health systems are all at a different place in terms of being able to have zero carbon energy, and wanted to compare this. And then we also looked at staff transit via surveys to our departmental staff and compared this to UCSF commuter surveys. And then knowing that patient transit is also part of scope 3, we looked at our department's treatment records to understand how far are patients traveling, and could even break this down based on what disease site they were being treated for. And then we spent several months training our collaborators at other sites on how to replicate this data collection. Again, so we could get a broad understanding of what was happening nationally. This has been a really fun and interesting process. I'll talk more about our results here nationally, but with the standardization of these LCA forms, we've actually been able to expand it internationally and collect data not only in the UK and Canada, but also in Ghana and Brazil, and even in Botswana, to start to understand where are there opportunities for mitigation internationally, and how can we take away some best practices from sites across the globe. But then at the end of collecting all this data, what you do is you can ultimately calculate the impact of all these components by breaking them down into their smallest units. So for example, a single medical glove, you then use databases and resources such as CIMAPRO, and you can translate this then into the different impact categories that I was mentioning before. And so we had a lot of interesting results from our study, but I want to emphasize that the goal of our study, again, was to quantify that baseline and then find actionable items for mitigation. So I'll just run through tonight a few of our interesting findings. And the first was that building energy use, which you can see here in blue, and transit, which is in yellow, accounted for the largest impact across all environmental impact categories. And we can see here, this is our greenhouse gas category, which many of us are most familiar with. And interestingly, supplies, which is in green and very hard to see here, was very minimal for radiation oncology. The second was that we were able to understand what the average emissions were per patient per treatment day, and begin to translate this into terms our field could understand. And so we found that each treatment course was about 4 tons of CO2 emissions. And so this is the equivalent to driving 10,000 miles. That 10,000 miles essentially would be driving the perimeter of the United States, or equivalent to taking 4 round trips from San Francisco to Virginia. And when we looked at building energy, we can see a significant proportion comes from the HVAC system, especially from natural gas, which accounted for 71% of energy use emissions. And so this is a great opportunity for physicians to be advocates within their health systems to transition away from natural gas. But here at UCSF, we interestingly are already in the process of doing so with significant decreases since 2015. So again, highlighting that there is some silver lining in all of this. And then we found actually that very little impact was coming from our equipment, with our machines actually producing about 4% of total energy use. And so that was surprising to us, but nonetheless, it highlighted that there's still opportunity to partner with industry who have been very excited to see physician advocates in this space. And then when it comes to transit was responsible for about 50% of total impacts in 6 out of 10 impact categories, accounting for 14% in greenhouse gas emissions, but over 99% of carcinogenic potential. And the reason why I highlight this is because of an intervention that we're doing at UCSF, which I will discuss here shortly. But addressing patient transit is certainly a very nuanced discussion and looks very different in each clinical setting and department, and actually for every patient. And as I mentioned before, interestingly, supplies in our specialty accounted for very minimal impact. And this is very different than LCAs, especially those done in surgery. So again, emphasizing the need to perform LCA analyses in different settings and in different medical specialties. And then for our field, we were able to dive in and run different simulations and discuss alternatives, such as what would happen if we implemented telehealth for consultation, or what if we used hypofractionation, use shorter treatments where patients come maybe not 40 or 25 times, but what if they're able just to come for 5 daily treatments? Or even what does it look like if we are advocates for zero carbon electricity within our health systems? And so one area that we decided to focus on here at UCSF was addressing our patient transit. So as I mentioned before, this is a very nuanced discussion. What do you do if patients require daily transportation for radiation treatment, and low footprint modes of transit, such as walking or public transit, are nuanced by social determinants of health, as previously discussed? Since many of our patients come to clinic via Uber and the use of Uber Health application, we transitioned and ran a pilot last year to see if patient transit emissions could be reduced by booking patients with Uber Green instead of conventional Ubers. And finding that not only were emissions reduced by 79%, but also there was no significant difference in price or wait times. And so we projected this out and found that we could save about 4.8 metric tons of CO2 annually just with the transition of patients who are already coming via Uber. And so now this year, we're continuing on a longitudinal pilot with Uber this academic year, showing to date that these trends continue, both with ease of booking, very few cancellations, but fortunately many emissions saved. And so hopefully creating an opportunity for Uber Green to be used more broadly across UCSF Health, and eventually across other health systems in cities where Uber Green does already exist. And then recognizing that LCAs can be very time intensive, and knowing that waste is still especially high in surgical specialties, we felt that there remained an opportunity to reduce impact in our brachytherapy procedural suites, a treatment that's different than external beams, but rather has a surgical component to it. So specifically within our department, we had learned a lot more about waste from our LCA, and we found that red bag waste in particular is not only financially costly due to the process it requires for sterilization, but also there's a significant environmental impact due to the incineration process and even the transportation that's required to get this red bag or hazardous waste to the appropriate facilities to be processed. And so in our department, we ran a procedural waste audit in which student auditors weighed and documented the procedural setup. And then they came in after the procedure and again weighed both the red bag and the non-red bag waste, or essentially the trash, and any unused supplies. And yeah, I just highlight this area. Usually I always highlight this for residents because I think it's a great opportunity to run similar audits in other departments. For example, we ran this as a QI project, as a GME QI project last year, really fulfilling all of those GME requirements. And interestingly, what we found when we ran our audit is that it was simply a lack of education of appropriate red bag waste disposal. Far too much was going into red bag that could actually go into landfill. And that was because the trash bin that sits right underneath the physician's foot was automatically lined with a red bag waste disposal instead of it being landfill, thus prompting more items to go into red bag at the end of the procedure when cleaning up. And so we realized if we simply exchange this kick bucket to a trash bag, that we were able to essentially completely eliminate all of our red bag waste, which you can see here on the right. And then recognizing that this audit only added 6 minutes to our workflow, we wanted to lower the threshold for other residents in clinics to participate. And so we created a tool for others to implement similar audits, which is now being used in residency programs, again, as a QI initiative to reduce medical waste. And then lastly, we were able to partner with an AI company called Zabel to reduce the audit down to only 60 seconds, as the app can take photos and spit out both the weight of the bag and then note the items that were disposed in there. So really allowing us to very simply expand this and move it into and keep doing this year. So these are just two examples of what can be done very practically in the clinics for mitigation. But certainly there's a lot of work going beyond mitigation. And going back to the beginning of my presentation, we can begin to think about how to protect our most vulnerable patients beyond having less waste. And so one key thing I would like also to be a takeaway from today is recognizing that climate action and climate solutions typically come in 3 flavors. And I like to think about these of 3 buckets of action. So there's certainly opportunities to move beyond primary prevention or mitigation, and then switch to both resiliency and adaptation or secondary prevention. And so understanding there are numerous tools, or I guess today there are numerous tools to further assess community vulnerability to climate change. And we'll highlight this tool, the U.S. Climate Vulnerability Index. And this tool allows you to see which communities face the greatest challenges from impacts of a changing climate. And the tool shows you what is driving these challenges, so policymakers and communities themselves can take action to build climate resilience where it's most needed. And then being on the front lines, I think it's also essential for physicians and researchers to better understand the specific patient populations that they work with, including clinic patients. And so this is a study that we are doing here at UCSF, which is looking at mistreatment visits during times of wildfires. And this was inspired by our national study that showed that patients had longer treatment times, essentially showing that they were missing their visits. So when we looked at UCSF, it showed that this was true with an increase of missed visits by about 2% during times of wildfires. And so right now, what we're doing is collecting data from UCSF and then 4 clinics across Northern California that were also exposed to wildfires, so we can understand why patients are missing visits and the impacts on their outcomes to, again, better adapt future resiliency plans. And similarly, there are numerous tools that integrate resiliency planning into clinics today and would highlight the AmeriCare's climate resiliency tools. And as you can see here, they have education materials and action plans that are not only for patients, but also for providers and even admin staff, and all tools that can be used to collaboratively build plans on an individual patient level or specific to the clinic. And then additionally, there are federal tools from HHS that can be used more broadly by health systems to, again, assess vulnerability, not only on an individual patient level, but on a facilities level to help build out these climate resilient healthcare facilities. And so the last question that I had was how to organize together to inspire change. And so, something, again, that I think this group knows quite a bit about, but we'll highlight the power of collaborative action. And, what started out as two interns, myself and another co-intern, seeing the impacts of climate change on our patients, developed into a resident-led group at Stanford called Greening the Clinics, and then a lab at UCSF called GreenHealth, that allows students and residents across the nation to come together and work on many of the projects I discussed today. But we also have been able to work within our specialties and created a resident-led climate and health group that then gained attention from our larger professional society called ASTRO, who actually responded, created a formal task force, and even passed policy this past June that is pertaining to climate change. But as we learned about from Joan today, there are also many other groups that have started to pop up in broader oncology, really from an international lens. And even, these groups have formed into formal working groups within the Cancer Center, specifically at UCSF. So, usually I talk about how, the value of talking about health, which I think this group understands, but I think, really, really rings true, especially after COP28 and, the value of bringing health into the discussions of climate change and future climate action. And so just want to acknowledge everyone who has been a part of our work, and thank you for having us this evening, and really look forward to more discussion tonight. Thank you.
Wonderful. Thank you so much for that. And I think there's positive feedback in the chat. There's clapping emojis. So again, thank you so much for all the work you've done, clearly making a difference for your patients and your community. So with the last few minutes here, we do have a couple questions. If anything else comes up, please feel free to post them in the chat. But this question is for Dr. Lichter. Can you explain a little bit more about what the Cancer Center hospital sustainability plans were? I think there was just two of them that you found. And so what were the focus of those, if you remember, and what was it more of health preparedness versus specific to weather planning and whatnot?
Sure. Yeah, absolutely. So when we look at cancer centers, typically they are required. All NCI centers are required to have emergency plans in place pertaining more to weather events that could take place. But really, we were looking at climate resilience, both from a facilities level, but also down to the individual patient level. And I'll say, although it was fantastic to see that they had, two places did have this in place, we really don't see it specifically addressing climate resilience, whether it's on the facilities level or the individual level. But we also were really interested in looking at sustainability or decarbonization and mitigation plans. And that's really where we saw significant lack and a lot of opportunity. As we have seen across healthcare facilities, a lot of the universities already predate us in having sustainability plans or having, for example, carbon neutral plans, or really, did they have things that the HHS pledge is asking hospitals to have? That's, how we were looking at it, is not only addressing scopes 1, 2, and 3, but looking at the components of the pledge and seeing if those were built into their sustainability plans, and really saw a significant gap there.
This question kind of bodes off that a little bit, but New Hampshire was saying how many hospitals and health systems are kind of reluctant to sign up for the HHS pledge. And so Emily was wondering if there were similar obstacles with decarbonizing cancer care and other barriers that people either perceive or are real.
Yeah, I think it matches that, with the pledge is, I think so many, we haven't done a why cancer centers don't have this, but, I can make what I think from talking, my assumptions from talking to cancer centers is, one, I think it lacks awareness. I think simply, understanding how climate change is impacting our cancer patients, the data that I'm talking about tonight, really, we didn't see data. We hadn't seen anything published on this until 2019, when the first hurricane study came out showing that also survival was reduced for lung cancer patients. And so often, when I say I'm interested in climate change and cancer care, people understand. I think it's very similar to the rest of healthcare sector. Yes, I understand how this impacts young children or individuals with asthma, but the link, and the awareness is lacking. And then I think second to that is the center's leadership don't know where to take action. And I think that's true with the HHS pledge. And I know, being a fellow at OCHI and HHS this year is, how do we make this easy and tangible? So if you have a pledge and you make these commitments, what do you do after the commitments? And I think that's where HHS and OCHI and Healthcare Without Harm and many of these other organizations have been fantastic in creating a guideline to help, whether it's leveraging the IRA to make facilities more resilient, or if it's addressing scope 3, creating a step-by-step process for that. I think, that's where some of the barriers exist. But I think more and more, again, as we lack awareness, I think more and more tools are coming out that we can share and really, guide and hold hands on some of these things.
Well, and two things that were in both of your presentations are really showing the evidence, right? I think all of us as clinicians have seen the effects, right? I remember, hospice being revoked during a heat wave for 2 patients who were on home hospice and didn't have the climate controlled setting and all that, right? And their families just didn't know what to do. And so I think all of us have all of these examples whereby there were floods or wildfires and transportation was impeded and disrupted care. But kudos to you and the teams you were able to form to really show the data, because that's the key missing link for many of these decision makers is really the data that drives action. Dr. Schiller, a question for you. So one of the beautiful things you've done with OUCH is really convene a whole group of individuals. And I'm just curious if you have any suggestions on how to form a team, because I think in cancer care, interdisciplinary, transdisciplinary teams are pretty common and inherent to the work you do every day. So especially those new to this field, in many ways, climate change, climate and health is a similar matter. So what suggestions do you have on forming teams and learning from other people?
I would say it has been difficult. The part of the reason we formed OUCH was because oncologists were either not aware of or interested in or were too busy to think about climate change. It was not within their bandwidth. And so they were expecting somebody else to do it. I guess my only thing would be to say we have to just communicate and get the word out there. The more we talk, the louder our voices, the more chances that somebody will hear us. And so that was the whole purpose of OUCH, was just to get the word out there, tell everybody that, climate change really does impact on cancer care. and now we've got people from 22 countries, involved in it. So it's just a matter of talking loud and hard, I think.
Absolutely. And I mean, there's a growing force of you already. I mean, you just had the webinar tonight. There's going to be, 300 more people that listen to this and join the club. I know it.
For
So
sure.
I think, what I'm hearing is we should all be really excited about what cancer care looks like, even in a changing planet, and even in the setting of air pollution and extreme heat, because we're transforming care. You're transforming care, working together with stakeholders and rethinking, what's next? How do we reduce our impact on emissions? How do we adapt and build climate resilient systems? And so I know I personally am super excited to see what happens, and wish I could consult all of our cancer climate doctors for every patient in the emergency department. So just very fortunate.
I would like to invite anybody on the call here or in your group who cares for cancer patients, be they physicians or other allied health professionals or patient advocates. Please give me a call. I just put my email in the chat box, which unfortunately was wrong. So it's ouchforclimate@gmail.com, not .org. And please get in touch. We have so much to do. We just really need to spread the word, I think.
Do you have social workers and other allied professionals as well?
Sure. Oh,
Yeah.
yes. We've got research coordinators. We
Mhm.
we have pharmacists, obviously a lot of nurses, a lot of patient advocates. So for sure.
Wonderful. Well,
Yeah.
climate action is for everyone, and we welcome all minds, all solutions. It will take us all. And so, again, thank you so much to Emily. Thank you to Dr. Schiller, Dr. Lichter, for all of your work. And we can stay on another minute or so, welcome other questions. Otherwise, thank you all for joining, and have a